Welcome to Managed Care. This is Module 5 of the program, and hopefully you've done your reading on this, and we're going to get into the introduction to why we need managed care and why managed care has been introduced. The high cost of healthcare, as we've explained, inflation of healthcare being much higher than the cost of normal consumer price index or inflation, means that sometimes healthcare is increasing at more than double the normal inflation, which means it's outpacing the increases that people have for their salaries and various other expenses. And it means that they're starting to not have enough money for savings. They're going to not have enough money if they're not saving to have capital available if something happens. So they've introduced this concept of managed care, and it's been looked at from a number of different sides. In the public sector, managed care was introduced and used extensively to ensure that HIV patients, were able to stay on the regime. When in the early days of HIV, the drug regime and the process was quite complicated, and people were missing their drugs, missing their various interactions they were supposed to have, and getting sicker and then developing full-blown AIDS and dying. They found by good managed care, they could in fact educate the patient to live a healthier lifestyle and improve their standard of living. They also found as people were having heart attacks but not dying from a heart attack, would then go onto a regime of eating more sensibly, reducing their stress and that type of thing. And that in itself improved the mortality of the person, the chance of them dying or having another heart attack or getting sick yet again. And all of this experience that was being gathered from the data that was available made it quite clear that if we could get people to live more healthily, and when they were on care, to manage that care, that they do it properly, the mortality level would become far more beneficial. So we need to understand health and understand what the health risk is. So once we start to understand what the real health risk is, you can then take steps to avoid that. We also started looking at different degrees of wellness or ill health. So it's not you're just sick or you're well. There's actually a continuum. And the continuum looked something like this, where in the middle you've got a neutral point, then you start getting signs and symptoms, and maybe even it develops into a disability or a serious problem, and the worst case scenario could in fact take you to premature death. And what we've been talking about now is all covered by traditional medicine. But on the other side, if we could educate people, get them to grow in that education and change their behaviors and self-actualize those, that becomes part of their normal lifestyle. So eating a little less meat, not smoking, not drinking excessively. Now, weirdly enough, when they were doing all this research, they did find out that if you drank sensibly, it in fact could move you to the right-hand side, to higher levels of wellness. And they found that people who have a glass of red wine with their dinner on a regular basis very often were healthier than those who drank nothing at all. But obviously, if you start to drink a bottle of red wine, then you start to move to the left-hand side of this thing. And the whole idea of this was to move you to the higher levels of wellness on the continuum. Looking at it in a slightly different way, you've got optimal health on one side, you've got chronic illness on the other side. This is looking at it from the other thing, and we've got prevention and treatment. But in actual fact, if we deal with the wellness issues, we're not going to get those chronic illnesses. Organizations like Discovery became aware of this through the actuaries looking at the statistics. And what they started to do was implement things like Vitality. Other companies have followed on with that with their own wellness programs. And what in fact happened with Vitality, what they did, and a lot of these wellness programs would be to look at lifestyle and encourage healthy lifestyle. So for example, with a lot of these programs, if you go to a supermarket and buy foods that are not packaged foods or mass-produced foods or considered as healthy foods, you get a discount on those purchases, which saves you money. If you do things, you go to gym regularly, they would in fact pay an amount towards your gym membership, because people who went to gym regularly and now ate more healthily were probably going to develop optimal health rather than chronic illness. Now you can say, oh yeah, but what if someone gets bitten by a mosquito or ended up getting coughed all over during the COVID-19 thing and developed COVID-19? Well, again, there were behaviors that we were taught during COVID-19 that it was a good idea to wear a mask. It was a good idea to avoid crowded places. A lot of it they legislated because the government was quite worried about the pandemic. But if you think about it, it was just good common sense. And so if you know that the flu season is on now, and you go to a crowded place, maybe it's a good idea to wear a mask. You're less likely to catch flu or COVID-19. Regular washing of your hands. I remember a doctor telling me that most people pick up flu through touching something and then touching their mouth or eating or touching their face, and it gets in that way. So having clean hands was something we were taught about to improve our wellness level during the COVID-19. Now, the stuff that we learned then helped us become healthier. Eating balanced food, eating more vegetables, eating more greens, cutting down on certain fats and eating other fats which are beneficial, and eating in a balanced diet rather than an unbalanced diet, all can lead you towards optimal health. Reducing your stress levels, doing things to actually physically reduce it, whether it's something like meditation or playing a sport or just relaxation and taking some time off to sit down and read a book. If that reduces your stress levels, it is going to move you towards that optimal health thing. And that, at a very high level, is what this was about. And the reason we want to do something about it is because of medical inflation. Medical inflation, as I said, is moving up at a higher level than normal inflation. So it means that if everything's going up by 5 or 6%, your medical costs are probably going up by 10 or 12%. Your salary is probably going up by 3%. So what's going to happen eventually is that you won't be able to afford medical costs because they are outstripping your increases in your salary. One of the problems we're having now is that there's high population growth rate, but the real economic growth is not keeping pace with it. Countries that are keeping pace are performing much better. High inflation rates are affecting the affordability. High employment levels, people are not employed and then can't save, can't put money aside for their medical problems if and when they have them. It's going to be a problem. Fee-for-service as a provider reimbursement can encourage over-servicing. So as we discussed earlier, when they started looking at medical aids paying a set fee for a service, suddenly started getting a situation where people would say, well, I'm entitled to a set of glasses this year, so I'm going to apply for them. And I remember when I was a trustee on the bank medical scheme, seeing cases coming through where people had bought a pair of very expensive sunglasses, but they were prescription, and they then applied from the medical aid for them. And they didn't really even need glasses at all. So those sort of things where the system creates a problem is something that had to be counted. And then it gets even worse, where you get actual fraud and abuse by members and providers, and we've talked about that earlier. Having insurance in itself can be a cost driver, is because if you've got insurance and you go, well, I've got this insurance, I've paid for it, I better get some benefit from it. If you get fragmentation of care, if you're getting some care from here, some from here, you sometimes are paying for things more often than need to be done. Over servicing is carried out with more clinical work that is necessary. So you end up having procedures in that which the doctor or the specialist is encouraging you to have, or society is encouraging you to have, and it's creating unnecessary expense. I remember when I first came up to Gauteng and I changed dentists. I went to this dentist, and I've been going to dentists regularly, having fillings. If I'd cracked a tooth or something, then maybe having a crown put on. And this particular dentist presented me with a quote to have literally all the teeth in my mouth filed down and changed to crowns, which I remember the cost at that stage was 70,000 rand, and we're talking 20 years ago, so that was a lot of money. And because he seemed to perceive, no, well, it's fine if you do this and you put this to your medical aid will pay. And I'm going, but do I need this? So I went and got a second opinion. I went to the dentist who is now my dentist still, 20 years later. And he looked at me and he said, no, maybe you've got a tooth at the back that is in fact deteriorating and you chew on that tooth. So that tooth could do with a crown. But other than that, the rest of your teeth are fine. They just need the normal sort of thing. So over-servicing is something which has caused an increase in medical inflation. Demographics, the fact that you've got an aging population can also increase your costs on your medical scheme. This is a problem that China is recognizing now, that they've got a situation that they've self-created where they did not allow people to have more than so many children. I think you were allowed to, at one stage only to have 2. That was even reduced to 1 per couple. And of course, if you're only having 1 per couple, the population starts to decline. To compound the problem is the Chinese people, because of their lifestyle and their food and their genetics, are particularly long-lived. So they've ended up with a large aging population with a smaller, younger population. So you've got less people paying into the fund, but the older people are drawing out of the fund. So the funds are starting to become problematic. The burden of disease that we discussed in the previous thing, the sicker people are, so the more problems that they start to have, there becomes a greater demand for service. If you can convert that burden of disease by making people healthier and fitter and encouraging them to do healthy things, the opposite is true, that you can reduce the demand for services. And increased consumer education and awareness has made people aware of illnesses. So they're going to their doctors and saying, is this a problem? They look at it and they go, oh yeah, that is a problem. And then they very often start saying, well, we need to do something about it. But in actual fact, maybe they didn't need to do anything at that stage about it. So here's medical inflation compared from 2000 to 2017, comparing medical inflation in blue to consumer price index. In other words, all the other items in red. And as you can see, medical inflation outstrips the normal inflation, and it's getting worse. It's getting wider and wider. It's not coming down. That needs to be brought under control, or else the cost of medical care will soon become unaffordable for the average person. Technology is a two-edged sword. When it's first being implemented, particularly in medical, as you know, you're getting less invasive surgery techniques like keyhole techniques, even robotic surgery now. And it's minimally invasive, so people are going, oh, I prefer it. But it is also usually, because it's new, higher cost. As with technology, it always comes in at a high cost, and as it starts being implemented and used, the cost comes down. But with higher technology does not always mean that superior quality is guaranteed. And providers are saying how to use equipment that could result in higher cost, and sometimes they're just saying no to it, where in actual fact, when you actually look at it clinically, the use of technology, keyhole surgery, may be a little bit more expensive. But if you don't use that and use traditional surgery, like an abdominal surgery where you open up the person, like completely open them up and do the surgery, there's more things that can now go wrong. And if they do go wrong, first of all, initially, full surgery is usually going to have longer time in hospital than a keyhole type of thing. So the medical aid, instead of paying for 5 or 6 days in hospital, is paying for 2 or 3. So although the initial thing is more expensive, the time in hospital is less. So all of these things need to be weighed up and looked at very carefully. Supply-induced demand. We mentioned the manner in which providers are reimbursed can influence the demand for services. In the past, when they've introduced methods of paying suppliers, your medical suppliers, sometimes this had the result of increasing the amount of service that was being given that not necessarily needed surgeries were being done and procedures were being done rather than not being done because they were not that necessary. So what then happened is money gets used up. So when people get seriously sick and there is something necessary that they need, it's not there. So when doctors or other professionals may have been creating patient demand where they may not have done if they were acting as agents for their patients. So very often this is when the economics and the capitalism side of it comes into medical, is that it starts running as a business. Now, again, I use this a lot. A lot of people say, oh, Ray, you really don't like America very much. And I just don't like their system. And I certainly don't like their medical system. And their medical system is a business first. And because of that, you have incredible high levels of cost caused by this supply-induced demand. Now, just an aside here, if you can get hold of it, because you guys are all medical people, there's a movie by a filmmaker called Michael Moore that I've mentioned it earlier. I'm going to mention it again. It's called Sicko, and he looks at the American medical system and what's wrong with it. He then goes and looks at France and various other European countries and how it's run there, and he makes a comparison. And I think let me tell you, he is not a balanced commentator in that he's making a point that the medical system is about money and people are being ripped off and not being serviced properly, where other systems where the system is about wellness of the people, improving the patient's wellness and health and moving them on that continuum to be more healthy. When that is done, the costs are contained. It's well worth watching, and I would recommend it to all of you guys. As I've said before, fee-for-service is often held to encourage unnecessary supply-induced demand. So the supplier sort of knows, if I do this, I'm going to get paid for it, so let's do it. The legislative factors. Our medical system, as we discussed it earlier, is open enrollment. They cannot stop you from joining a medical scheme. So that immediately puts pressure on, if you're very unhealthy and you're going to cost that medical scheme a lot of money, they cannot deny you. They've got to say, They may set up a waiting list or a time period that you've got to wait because you're new in the system, but they cannot deny you completely. The community rating system is where they look at the community and they rate based on that, not on individuals. And again, that means that it's a more generic cost rather than the very rich paying a lot more than the very poor. Our legislation only allows, and I'm talking about in medical schemes, limited underwriting. If you are new to a scheme, you want to join a scheme, they can underwrite you and maybe make you wait a little longer before you get payments. But they cannot, like they do in life insurance, decline you. In life insurance, if they check you out, send you for a medical, and the doctor comes back and says, well, this guy's got a serious heart problem, they can then turn around and say, either we're not going to cover you for life cover at all. Thank you. We're not going to take your money. You can't join. Or they'll say, we will cover you, but if you die of a heart attack, we aren't going to pay you. Now, neither of those options are allowed. Underwriting options are allowed in our medical schemes. Prescribed minimum benefits, which were introduced, and we've discussed this in the previous modules in detail, that there's this list of 200-odd situations that come along, and it literally means that those prescribed minimum benefits are completely fully paid. There are no co-payments, there's no deductibles, and there's no limits on it. The lack of a mandatory membership, which undermines the cross-subsidization of healthy to sick. In a pension fund in this country, since 2016 and implemented in 2018, everyone that is employed must belong to some sort of private or company pension scheme. You can do your own private retirement annuity for yourself, but you have to have one. And your employers are forced to deduct amounts and pay it on your behalf into these schemes. The same is not in place for medical schemes. I mentioned earlier I was going for a checkup on something. We were at the doctor's and we were talking about things. And the lady behind the counter who works for the doctor said, oh, she's not on a medical aid at the moment at all. And we were quite shocked. I mean, she sees what happens to people and the costs and that type of thing, yet she's not, because she's saying, I can't afford it. Well, if it was mandatory that everyone, like they have with pensions, everyone who's employed must belong to a medical scheme, even if it's a basic health or hospital plan, which just covers your PMBs, that would be better than the current situation we've got. And this is one of the things that the National Health Insurance Act, which is currently being implemented, is going to change within our system, in that everyone will have to belong to the National Health. And if you want to have extra medical care, you would then belong to a Discovery, a Momentum, a Sanlam, or whoever. The lack of price regulation in the private sector, with the exception of drug pricing, can be a problem. So various medical specialists who are highly in demand can in fact charge far, far more than there's no regulation to control that, than medical aids are prepared to pay. I've seen 5 times the medical aid rate, and it can even be higher than that. In South Africa, with drug pricing, it's a little different. That is controlled. We have legislation which, in fact, controls the pricing of drugs. This was not the case in the United States, and I think I've told you the story of an HIV drug, which was owned by a company. A wealthy investor bought the company and increased the price of the drug by a couple of 1,000% or 1,000%, not a couple of 100,000%. And that kicked off a movement within the government to bring in legislation in America to ensure that that doesn't happen in the future. And then the other thing that the current president has been, President Biden has been working on and getting implemented, was to build in a regulation to control the cost of insulin, because they found that insulin, which if you're a diabetic and you don't take your insulin, you die, was being pushed up by profiteering drug companies. And he has brought in legislation to put a ceiling on those costs so that they can't go up too high. Because of all of this, it places schemes in a more vulnerable position because of anti-selection for all of these. The closed schemes, where scheme membership is not a condition of employment, is also at risk. But where you've got let's say you work for the Metal Workers Union, and they have a medical scheme which says if you're a member of the Metal Workers Union, you must be a member of the medical scheme, and it's compulsory. Then everyone, the young, healthy people, have to join, as well as the old, not so healthy people who want to join desperately because they need the cover. And you then get the young, healthy subsidizing the less than healthy. Anti-selection is a problem, because what happens is if you do not get this cross-subsidization of the rich subsidizing the poor, the healthy subsidizing the not healthy, and so on, then it puts the medical scheme under a lot of pressure to be able to successfully exist. And they pay out too much. Well, pay out too much means they're paying out more than is coming in. They become unstable. They can't meet their reserves. This can be fixed through a pooling of risk, which we've discussed, the concept of pooling of risk, and we make it compulsory membership so that all people have to belong to a medical scheme to balance this out. Steps in the risk management is identify the risk. So discovering the sources from which losses may arrive. What sort of things are going to cost a lot of money? If this happens, what's going to cost money? Then evaluate those risks and think about what would be the impact to an organization or individual if such a cost occurs. And then how do you control that risk? In other words, you come up with efficient techniques to minimize the risk. And you make financial provision to fund or finance the loss should it occur. Now, if you follow this process, it means that when these situations happen, they are not a surprise. We've planned for it, but we also mean that we've been able to put techniques in place to minimize the risk. So if you have a look at the 5 steps, you define the population, you look at the care gaps, where are there gaps? You stratify the risk. You look at the risk and you go, this risk is big. And also when you look at these risks, the whole thing is you go, is this a risk we can do something about? So for example, up until recently, people would say, having heart attack is just a hereditary thing, or cancer is a hereditary, which is not untrue. It is in your genetics. So one of the things they've been able to do is they've been able to look at, you can go for genetic screening, and then they can tell you if you have a chance, if you're in the population that is going to possibly have a heart attack or develop cancer. Now, where it gets even better, they have now been able to identify things that, in fact, if you have those risks, if you manage them, you can reduce them. So, for example, if you come from a family that has a lot of problem with bowel cancer, one of the things they've picked up with bowel cancer is eating too much red meat, eating too much processed meats, eating stuff with, preservatives in it. All of those can, in fact, increase your cancer. So if you say, I'm going to reduce the red meat and eat more fish and poultry, or I'm going to go vegan, they have found, being vegetarian or vegan is very often seen what Looney Tunes type people like to do. And there's a joke, how do you know if your friend has become vegan or someone you've just met is a vegan? Is that they will tell you that they're a vegan. But having said that, vegetarian and vegan diet, actually, one, it reduces your costs, so you're not buying meat. Trust me, your costs come down. But secondly, there are definitely diseases. So if you were from a family that was prone to bowel cancer and you went vegetarian or vegan, or even just ate more fish and ate less red meat, your chances of getting cancer become down. Now, the other part of managed care is not just eating. If you've got bowel cancer, you go for regular checkups for it. There's a camera scan that they can do, and it can, in fact, get very, very early warning. The polyps that they pick up, they can snip off from inside your bowel and inside your intestines and pick up if there's a potential, if they are potentially cancerous in the long term, and in fact snip them off so they don't grow into a full-blown cancer, which causes a bowel blockage, which causes you to go in for emergency surgery and then spend an extensive time in hospital recovering from that, and then go on to chemo, and then have to have a reconnection operation to fix up the stuff that was done in the original surgery. So managed care is a broad-based thing of things we can do once we've picked up the risks to make things better. Then, of course, what they're doing is they're measuring the outcomes. They're going, has this actually helped? So companies, I remember I'm not going to mention the particular company by name, but it's one of the big companies which have a medical scheme with that encourage you to improve your lifestyle and reward you for it. And I was looking at the figures, and I was at a meeting, and they were sharing figures of how much it reduced the payout. So the payout on the medical aid, I thought, if it went down by 10 or 20%, that would be good. And it was reducing the payouts on those type of things by 50, 60, 70%. It was having huge impacts on the actual payouts for the medical scheme. The same was with life insurance. If you had someone who had a life insurance policy and then was using Vitality or Multiplier, one of these life care sort of processes, and they changed their lifestyle, went to gym, ate more sensibly, exercised regularly, reduced their stress, the drop-off in those diseases was dramatic. And of course, the drop-off of the payment that had to be paid out either by the medical scheme or the life insurance company came down, which increased their profits, which meant within a medical scheme, there was more money available to pay for the important things. So the aim of managed care is by using risk management to eliminate wastage out of the system, by ensuring that the right patient gets the right treatment, the right place. So you're not, if you've got a treatment that you can do as an outpatient rather than early on because you've picked it up early, rather than the person being hospitalized or being hospitalized and being in high care or intensive care at the right time. In other words, you get these things early. You'll hear this with cancer, whether it's breast cancer, bowel cancer, any cancer. If you can find it early, pick it up early, treat it early, the treatment is usually less expensive, less invasive, and you become a lot more likely to survive the cancer and live comfortably afterwards. I know in my particular case, they said we picked it up, and when you had the surgery, it removed it all. So that's why 10 years later, I'm sitting here comfortably as someone that had cancer 10, 11 years ago and is now living essentially cancer-free. That you get the right provider to do the procedure. So in other words, if you need an oncologist, you use an oncologist. If you need a specialist surgeon, you get a specialist surgeon. And then at the right cost. Because you don't want something, particularly when it's life-threatening, that you go, well, yeah, we can fix that, but it's going to cost you so many million, and then you go, well, I can't afford that. So your option is go home, take painkillers, and die quietly. I mean, that literally is like the option. So managed care is a powerful, powerful tool within the range of tools that are available to help control and reduce costs of medical care and to ensure that people are going to survive. The regulations in the Medical Schemes Act defines managed care as clinical financial risk assessment and management of healthcare to facilitate appropriateness. Think about this, that you're getting the appropriate and cost-effective service rather than an inappropriate and hugely expensive health service within the constraints of what is affordable through the use of rules-based, clinical-based management programs. So you're not making decisions on emotion, you're making decisions on what you're going to do, what needs to be done based on rules-based and clinical management-based programs. In other words, it's based on the science. The definition of managed care in South Africa has shifted more towards the risk and management of risk. It's one of the ways they limit the provider with the designated service provider networks and moving away for a fee-for-service reimbursement were an important part of implementing a successful management care program. So very often they'll say to you, listen, you go to a particular doctor or set of doctors, and we will be offering you the full management care as part of the payout of this medical scheme. Now, if you say, but I don't want that, I want to just do what I want to do, then you may not get the full payout. So to get the support, the financial support, you've got to follow the managed care program. The current medical schemes have created an environment of open enrollment and community rating. In this environment, schemes need to compete on the basis of cost-effective healthcare delivery. So all the schemes are on the same boat. You haven't got some that can let people in and decline others. All of them have to accept everybody. So the way they can compete is on the basis of cost-effective healthcare delivery. And companies like Discovery and Momentum, who have got Vitality and Multiply, have definitely learned that this can give them a bit of an edge over the other medical schemes. Managed healthcare combines clinical, statistical, financial techniques to maintain risk, reduce cost, and improve quality. And this is done by encouraging the delivery of cost-effective, high-quality healthcare to its members. The principles of management care is to influence the utilization, cost, and quality of health services so that we utilize them at the right place, the right cost, and at the highest quality. That it creates a patient access and referral system so that they can get access to the managed care. It puts restrictions on the member's choice of healthcare provided. Very often they've got designated service providers. A gatekeeper model is often commonly used, which is what I said. They actually have, if you're going to get this payout from the medical scheme, you're going to have to get it using managed care. If you're not prepared to use the managed care, or if you obviously don't use the managed care, then co-payments are going to kick in and all that type of thing. Members are required to select a primary healthcare provider from the participating providers. The big medical schemes have been very often able to, in fact, negotiate very good, much better rates with the providers by ensuring that they get paid on time. If they do things correctly and follow the managed care process, they will be paid quickly and on time, and not have to wait or run around and prove that they've done this work. Members are only allowed to change their primary care provider subject to a formal procedure as specified by the medical scheme. So you can't just change things because you feel a little less than happy. You are on a process. It is the whole process is what you have to buy into. The contract between the healthcare provider and the health benefit administrator should clarify these issues. Where services must be authorized. When, like this service has to be authorized, pre-authorized before you have it done. When services must be referred. When do you refer from one provider to another? A limitation on services. It'll actually say you can have this and this. We talked about it earlier. One of the complaints people have often had is that they would want to have the most modern, latest, up-to-date, technology-based service, and sometimes that has been limited, and they said, no, you can have this operation, but it's got to be done the traditional way, not the keyhole way. There have got to be risk-sharing agreements between the various parties of the managed care procedures, and the goal is to access the most cost-effective service at the most appropriate level according to the members' healthcare needs. Okay. Selection of a managed care company. Now, some bigger providers could, in fact, create a managed care company and have it in there, or they could, in fact, go to an existing managed care company that provides this sort of thing. And this is probably the most important. Managed care companies are for-profit companies, and their cost contributes to the healthcare expenses of the scheme. So that we must take into account this in the selection of the best managed healthcare for the program. Are they accredited? Are they accredited with the council? Has the council done an audit to ensure that they have the necessary financials, skills, and infrastructure to provide the service? The scheme must ensure that they have carefully selected the appropriate company to meet their need at the best price based on the risk assessment. The old adage is if you cannot measure it, you cannot manage it. So managed care needs to be a process that includes mechanisms that ensure that members receive an adequate quality of care and cost savings, and it must be measurable. If it's not, then it becomes a little airy-fairy and will probably not work very well. One needs to have a baseline measure before the program is implemented and then monitor after the program to evaluate the quality indicators and cost savings versus the cost of the program. So you're buying into this thing called a managed care company, which is going to provide these services. Now, what you need to do is be managing it and measuring and say, well, if we don't provide these services, what would the result be? That's your baseline. If we do these, what should be the improvement? That becomes your new target. And then you look at it and you say, well, we spent this money paying for this managed care, but did we get a reciprocal increase in performance? Providers are asked to be aware of treatment guidelines and to explain variability from the guidelines. So the managed care will in fact set out these are the treatment guidelines we are going to do. If they vary from those guidelines, they need to be able to explain it to the financial service provider. There's got to be improved access, so people have got to be able to get hold of it, get into this and use it easily at the different levels. The cost must be efficient and must be the price must be transparent. If this cost is like a hidden cost inside, it could just get pushed up, and people will be paying for this managed care, but in actual fact, the benefit of the managed care is not at all obvious. The reimbursement mechanisms must be set up and tested to ensure that they have sustainability and healthcare provision. In other words, the reimbursement mechanisms from the managed care must be paying out in a way that the scheme stays financially viable. If they've implemented this and are paying out more money, and it's costing them more money to run it, then that's a problem. And then there's got to be reporting. In other words, proof of these outcomes. Quality needs to be measured. So in other words, what is the impact on scheme members? Are they healthier? Are they spending less time in hospital? Is the results better than the average before? And then you got to look at how is the quality measured? How is it monitored? And compare indicators with local and international standards. So if we start to see people are surviving longer after this treatment and implementing managed care, we then got to look at local standards and say, well, is this being found elsewhere, and is it being found internationally? Now, if we are ahead of international or the local standards, then it means that this managed care is having an impact. Demonstrate the use of protocols, formularies, and illustrate focus on health outcomes. So in other words, that you're not making decisions on a sort of knee-jerk, that you're looking at a protocol. This is the protocol that we implement that will be followed, and the formularies would relate to the drugs we're going to use, and that these drugs are the most cost-effective and efficient for this particular thing, and that everything is focused on improving health outcomes. So these are some of the things that we would use as benchmarks to look at, is this working or not? So patient mortality rate. Are the patients who are going through this process living longer or having a better survivability than the average? The specialist referral rate. Are people being referred at the right time? Because very often people were referred too early to a specialist, which increased the cost of things, where they could have rather been treated initially and then referred to the specialist at a later time. Converse to this, very often if there's a problem, as we said with cancer, it may be a good idea to refer to the oncologist or surgeon earlier, because that will ensure early decisions, early action. The hospital admission rate, how many people, because we put this process into place. So you put the process in place, and the idea here would be to try and get outpatient type service for the client and reduce the hospital admission rate. So if you implement it for these procedures, are we getting less hospital admission rate? Can it be done just through treatment out of hospital? Or are the hospital admission rates going up? Procedure complication rate. So when these procedures are done, what is the normal complication rate? And if we implement our managed care, what is the procedure complication rate now? And if that gets better, it means that the managed care is working. And if it gets worse, it means that, well, something's not working. And then the other thing is patient questionnaires, because this managed care puts a lot of, it makes the patient have to comply with a lot of rules and that sort of thing. And sometimes this can be a bit onerous. So it's quite a good idea to find out how the patient is feeling about this. If this process is not explained and the patient is not educated correctly from the start of what managed care actually is and how it's going to help them, you could have very disgruntled patients at the end of the process. They may be healthy, they may have lived, they may even be healthier than they would have been and they're now alive where they could have been dead, but they still could be disgruntled, and you need to find out what that is. That maybe the education process needs to be speeded up. The sort of treatment guidelines schemes can ration funding for services using, as I mentioned, formularies and protocols. So in other words, it says we're going to ration it that if there's evidence-based that this person has, we'll use medicine that we have evidence will fix the problem, if that makes sense. We will implement protocols that we have evidence will improve the thing, and use medical professionals to make the funding decisions. As I said, with PMBs, this is already implemented in that the decision of if something is a PMB is something that is done by the diagnosing physician. So if the diagnosing physician looks and says, you have this, and this is a procedure you need to have, and then what they've said you have is on the list of 200 odd PMBs, it is a PMB, and the rules of a PMB would kick in. If, however, they say, no, you don't actually have this, you have that, and it's not on the list, they're the ones that make that decision. Now, obviously, the patient would be going, I'd rather it was on the list because then I don't have to pay any co-payments, but it's not based on that, if I can say, situation. It's based on what clinically the professional decides. The evidence-based medicine, or EBM, seeks to clarify those parts of medical practice that are in principle subject to scientific methods. So in other words, we don't look at prescribing a medicine because a very attractive young lady came and gave you big gifts and freebies and took you to lunch to start using this medicine. They base their decision to use the medicine on evidence that this has worked in the past and that they can base it on evidence that it has been used successfully. It makes conscientious, explicit, and judicious use of current best evidence to make those decisions. So that is something that's changing all the time. So, when the drug is invented, it goes out for trials, it goes for clinical trials, and then you'd have the first lot of evidence of does this work or not work. Based on that, it gets approved because it obviously does work, but then it's being used over time, and that evidence is constantly being added to. And you could, in fact, find other things that drug is helping with, or you could find that there are other drugs that have come along that are cheaper that actually do it better. Protocol means a set of guidelines to the optional sequence of diagnostic, testing, and treatments for conditions. So in other words, it's what could have happened in the past was that a doctor would be going, I'm not sure what's going on, let's have a scan. And they'd call for a scan. But before they did the scan, maybe they should have done a blood test and then done an X-ray and then done the scan. It should have been done in a line like that, because maybe the scan wasn't necessary. One of the other twos could have, in fact, clearly shown that the process is in place. And once there's a protocol in place, you don't get, if you like, people, doctors or medical professionals jumping the gun and doing things that could be very expensive to the fund that are not necessarily successful. Clinical pathways are care pathways. This is a process that they've found out. If you have this and we do these things, this will in fact lead to a better end to this process. I remember when I went in for serious abdominal surgery, the specialist surgeon insisted that I had to wear these like socks to ensure that I don't get any blood clots in my legs. And they were the most uncomfortable irritating things to wear. And I really hated them. But that would be part of the clinical pathway. You'd say, if we do this, we know that this will in fact ensure that you don't have this problem, which is going to cost more money, more hospital time, more chance of something going wrong. I remember also after this operation, part of the clinical pathway was to have a physio to look after me. And at first I was going, what the hell? He was teaching me how to breathe properly. And one of the things that they found at this particular surgery, that it affected the way you breathe, and you've got to quickly start breathing correctly. And that will, in fact, has been proven to help you towards the part to a successful end. The other thing is people who have quite serious surgeries now, you'll find that they will be being got up out of bed, walking around much earlier than used to be done in the past. Because what they found is, if you get the person up and moving, and get this working, the whole thing becomes a lot more prone towards success. So this is a multidisciplinary management tool. So you've got different people. I remember when I had a serious, what happened was they were going to do an operation to reverse the whole process, which went wrong. And I ended up in intensive care for a while, and then hard care. And I ended up, I had a surgeon, an oncologist, a specialist physician, and a specialist dietitian, because I was on a specialist. I couldn't eat because I wasn't allowed to eat at all for quite a period of time. So I was on a special drip that fed you, but the drip messed up your sugar levels. So it actually forced me into being a diabetic for a period of time while I was in hospital, and they were testing me for. So there was this whole team of people, and they had all these rules and protocols in place, what I could eat or what I couldn't eat, getting up and getting exercise, moving, and so on. And those are the medical guidelines or clinical guidelines that create this protocol, which is the clinical practice guideline. And they're saying, if we do all of these steps and all of these people look at it and keep you moving, the chance of you getting better and surviving gets better and better and better. And that is how the whole concept of management care works. There's a number of bodies that have been trying to put together information on protocols, and this is an international U.S. National Guidelines Clearinghouse for protocols. Milliman USA Care Management Guidelines are drawn up by actuaries and clinical people to in fact put together these things. If you do them, will in fact improve your survivability and getting better quicker. Cochrane Collaboration, and then the National Institute of Clinical Excellence, or NICE. Managed care defines the entire area of cost saving and health delivery. So in other words, it's done to bring down costs so the fund doesn't run out of money, but it also does it to ensure putting infrastructures in place and control measures to ensure that quality healthcare delivery is provided by influencing the follow. The price of the services need to be controlled. One of the things that I picked up in watching the program on that I mentioned to you earlier, Sicko by Michael Moore, is drugs that people were using in America. There was two things which was picked up, that they were being heavily over medicated. They were being given a whole lot of drugs that actually were doing the same thing. They didn't need all of them. they could in fact drop those drugs down. And the cost of the drugs, I remember I mentioned this earlier in one of the previous modules, they had a lady who was using an inhaler which cost $1,000 for that inhaler, and she needed 4 of them. That was $4,000, and she couldn't afford it. So she was trying to get by on 1 or 2 a month. That same $1,000 inhaler at the chemist in Havana, in Cuba, in Havana, Cuba, was like $12 equivalent price. And you go, how could that be? Well, the $12 was a generic thing, and it wasn't sitting in a system that is profit-based. So you had a drug company in America who was ripping the people off. You had doctors who are over-prescribing because they're encouraged and are remunerated if they will prescribe more drugs. So, I mean, the one guy went to the doctor that looked at it and said, look, but you're on 11 pills. You need 2. Take these 2, you're going to be fine, type of thing. So price of services need to be controlled. The utilization of the services, in other words, utilizing them correctly, taking the medicine. I mean, this was HIV. They found if people didn't take their drug regime in the time way that it was supposed to be done, it could in fact impact heavily on them developing full-blown AIDS or remaining as HIV positive. The performance of health delivery systems makes it possible to analyze the process and results of medical treatment. So this is the important part of this whole thing. If we're going, if we do these things, we've been told that the protocol works and it makes it quicker, but does it? And as each patient goes through the process, the medical schemes are keeping a record, and they're going, well, because we put these people through this protocol, they were in hospital for less time, they had less problems, so there was this much less cost. We have analyzed the process and the results of that treatment. Develop and communicate guidelines for effective and cost-efficient care. It's very important that this gets communicated to the healthcare professionals who are involved in the process, but also to the patients. Because if the patients don't understand it, when they're told, no, you can't use the original drug, we're going to give you this generic. I know how you feel. You say, don't tell me what I can do. I will do what I want to do. But then you're not being the most cost effective. And if we understand it as a patient as to why this is being done, it's not being done so the medical scheme can make a big profit. The medical scheme is not allowed to make a profit. We're doing this so that there's more money in the pool at the medical scheme. So if something seriously goes wrong with me, there will be money available. My medical scheme is not going to become unstable. Build networks of providers to improve and maintain the cost effectiveness of healthcare delivery. As I said, a number of the big providers of funding, healthcare funding, have put a lot of time and effort and consider that their network of providers that they now have as one of their huge competitive edges that is going to enable them to provide better service to their people at a lower cost. To coordinate communication and continuity of healthcare amongst providers, patients, healthcare benefits, administrators, employers, and government. So this is exactly what I was saying earlier. If you are doing these things for a reason, all the players need to understand that reason. So if they don't understand it and don't buy into it, then you're going to have people along the track fighting you. And this then enable and facilitate access to the most appropriate healthcare services, so that you must have the funding and the ability to ensure that your members, and I'm speaking now as the actual healthcare funder, that you know that your people can get the most appropriate healthcare services, and I will enable and facilitate access to that service. Holistic patient-centered care made me a little nervous at first, because very often when people start talking about holistic, they start talking about other medical systems, traditional medical systems and that type of thing. And not that I don't buy into it at all, but it's not about providing that you can go to your local person in the village who is going to herbalist or whatever. And very often they will not be covered as potential to be paid out. But what they're saying here is patient-centered care is not technology-centered. It's not doctor-centered. It is not hospital-centered. It is not disease. It is actually patient-centered. You've got to look at the patient's needs, and put together a plan that in fact resonates with him and works with him. Explore the main reasons for the visits, concerns, the need for information that they have. Seek an integrated understanding of the patient's world. That is their whole world. What is their emotional needs? What are their life issues? Find common ground on what the problem is, and then mutually agree on the management of that problem. If you don't do this properly and you sort of leave the patient out of it, you could have a patient who is going to literally fight you along. I was talking about those stockings that the surgeon was insisting. They never explained to me why, and they were very uncomfortable. So what I would do is, when no one was looking, under the blankets, I'd just whip them off and throw them off. And then the surgeon would come around, throw a little fit, not talk to me. He would moan at the nurses and this, that, and they would come along and, "Oh, Mr. Stroll, you've got to have these things on." And they'd pull them on. And I was still going, why must I have them on? Why must I lie here absolutely bloody uncomfortable? And no one explained to me. And to be honest, that particular surgeon, I think, missed the boat. Unfortunately, sometimes surgeons are not the best people. And he just you will do it. I'm the surgeon. I'm telling you, if you want to live, you do it, And when you're someone as bullheaded as I am, you need to explain to me the reason why. Once I understood the reason why, in fact, what happened was the head sister in the thing came and spoke to me, and she said, "Do you know why you're wearing this? Do you know?" And I said, "No." I said, "It's just I've had abdominal surgery and I've got bloody things on my legs. What the hell is going on?" Then she sat down, took a bit of time, explained it. And then I went "Oh, I understand that." And then I didn't fight it. I didn't enjoy it either, but I understood why it was there. So it enhances prevention and healthcare promotion. I was now, okay, I don't like this, but I'm on side. It also enhances a continuing relationship between the patient and the doctor. If the doctor doesn't explain things and educate the patient, then the patient is not going to literally listen to the doctor, and the managed healthcare is going to fall down, because the patient is definitely a part of it. Now, the managed healthcare things has a payment and reimbursement method. Risk is an intrinsic factor associated with the provision and financing of healthcare. The method of payment determines the level of risk. We discussed this. Fee-for-service payment, which was done initially, actually caused more payments, more expense. So the relationship between risk and reimbursement is such that the higher the risk, the higher the compensation. And conversely, the lower the risk, the lower the compensation. So the risk profile for each method is different. So if you've got a healthcare provider who receives a fixed salary for rendering a service, in other words, you'll see this if you belong to a medical scheme of the mine. They very often will have a doctor on the mine who earns a fixed salary, and much of your medical will be provided by that person. So they get paid for hourly, daily, or monthly. Fee for service. The service provider receives a payment for each service they do. The cost of each unit is attached to the calculated tariff schedule. As we said earlier, fee for service can encourage over-servicing. Active reimbursement methods, or ARMs, where there's a fixed fee payable, is largely used to compensate hospitals for services provided. It can be modified for other services, and there are variously fixed fee payments. There's a global fee, a fixed fee to compensate the provider for an event or a stay in hospital. Regardless of the length of the stay, the fee paid would reimburse all medical practitioners and at the hospital for a specific event, for example, confinement. Per diem. This is a set payment per day in the hospital regardless of the services or the actual costs incurred. Capitation fee. This is a payment structure in which the funder prepays a provider a fixed amount for each member's medical care for a predetermined period, regardless of the use of the services. The contract usually clearly specifies exactly what the fee covers. Getting designated service providers, or DSPs, means that the healthcare provider, by means of contract with those providers and a medical scheme, they create a contract and they say, you will provide services to our people at a set rate, at obviously a standard of that we should exceed. A healthcare provider or group of providers selected by the medical scheme as the preferred provider. So this is very often, if you go, medical schemes will say to you, if you go to our preferred provider, there will be no co-payment. If you go to your own, if you don't want to use this, you want to go to someone else, then there could be a co-payment. The benefit of this is that the funder or the scheme is the ability to select providers that have agreed to a preferential tariff in return for more patients, have the best health outcomes for a patient, less error and complication rates because these are being checked. If you've got a preferred provider who is having far more mortality than another provider, that provider is not going to be on your list for very long. Has jointly bought in to the reporting arrangements that are in this managed care process, and have agreed to the protocols and the formularies. In other words, they're saying, yes, we will follow those. Not that I'm going to do my own thing. I'm the doctor. I know best. Utilization management is primarily a cost containment activity aimed at monitoring and reducing utilization and costs of unnecessary treatments or procedures. Just to give you an idea, one of the things that has in fact helps a lot with this is the new generation policies have the savings element. You can put a percentage of your money into saving, which can then be used. Well, let me tell you, if you are utilizing that, it's your money out of your pocket. It's not coming out of the fund, so it doesn't hurt the fund, but you also feel that because you're actually paying for it. And so you've got to be a pretty stupid person just to pay for something that you don't really need, which you may have paid for if it was just coming out of a fund and not affecting your pocket directly. It's important that utilization management is tied together with the other parts of managed care. If it's not doing that, the savings costs can be very often at the expense of health outcomes. So if you're not doing this properly, you could maybe be saving money, but your people could be getting less effective health care. One of the effectiveness of utilization management programs is that there's usually early identification and rapid intervention on an appropriate, cost-effective, safe treatment plan for the patients. Now, we've talked about this earlier. There are certain diseases that if you pick them up early enough, do something about it, the actual interaction is quite minor. The there could be no stay in hospital required. It could be just a drug treatment and problem solved. For example, a lot of doctors now, when they test you, will be looking out for early onset of certain diseases, and then will put you onto a regime of pills or of drugs which are designed to, in fact, ensure that that doesn't develop into full-blown diabetes or something like that. That you've got a utilize and review program that goes in line with the review of provider remuneration structures. So if you're looking at having a provider who's on your panel, and you utilize this utilization review program, and you're looking at, you could in fact say, we're paying you this fee, but in actual fact, we're not getting our money's worth, because in fact, your success ratio is getting worse and worse and worse, or is much worse than the average. Following the protocols and following your success ratio should be here. You could either have those remuneration structures changed, or lose the process altogether. So some of the techniques is prospective review or pre-authorization, so that the medical scheme is given a heads up that the doctor is wanting a procedure, and before you can do that procedure, you have to apply to them. They then look at it. They may call for further information. And then they will then they'll pre-authorize. If you don't pre-authorize and just do the procedure, they may turn around and say, although this was should have been 100% payment, we're going to want a co-payment, or there's going to be a shortfall. Case management was what we've been talking about along here, is where you have a team of people managing a case to, in fact, improve the outcome, and try and improve the outcome at reduced cost. A retrospective review is that when people have gone through the process, the patient has finished the process and they've either got better and moved on with their lives, or worst case scenario, they've passed away, or they've had complications which have cost a lot of money, and then finally ended up with a fairly severe prognosis, but they're still alive. You then do a retrospective review and say, okay, were the protocols followed? If we are following these protocols, we should have got a better result of this. What went wrong? What caused it? So we've talked about pre-authorization. This is anything that requires prior approval. The system is able to approve or decline certain services. So the system would look at it and it'd say, if the doctor said you've had this should be done, yes, it'll be approved. There should be a provision, however, in this for emergencies. It links authorization to claims payment. So as I said before, if you've pre-authorized, it's 100% paid. If you don't pre-authorize and just do it, you could end up having to pay 20% or whatever in yourself. The authorization is linked to the payment by way of an authorization number. Usually what happens is you get an authorization, the system produces a number, which then gets put on the account, which is then sent in. There's a data requirement. The process, as well as the information needed for authorization, should be clearly defined to patients and healthcare providers. So there's data that has to be gathered before you apply for this, and it is then becomes part of the data capture of this. The focus is on ensuring that the procedure is performed in the appropriate setting. In other words, does it need to be done in a operating theatre, or can it be done in a doctor's surgery? Ensure that the members are valid members. Educate members on their benefits, like sublimits and disease management programs. When you're applying for this pre-authorization, they may say, you should be doing this as part of a disease management program for this. Ensure that the member does not have any exclusions on there, and that the procedure is covered by the benefit. Once you've gone through all of this and you've advised it, it then the person can then go through. The process of case management begins with the identifier of high-cost, complex care individuals who meet the criteria and can benefit from case management. So this is people with complex, expensive diseases which require quite complex management. To determine the ongoing services are reasonable, medically necessary, and covered by the benefits. So your case management will in fact be looking at this and going, yeah, what you're doing is necessary. The service The functions of case management include that the case manager gathers all the relevant subjective and objective data by information obtained by interviewing the client, the family, as well as the healthcare providers. All information related to the current treatment plan would be evaluated objectively and critically to identify barriers, clarify outcomes, and determine realistic goals and objectives, and in so doing, seek potential alternatives in order to achieve the stipulated outcomes. It's important that the case manager recognize the importance of the patient's involvement in a successful assessment process. As I've said earlier, if the patient is left out of this circle, they can be very obstructive to the whole process. The next step is planning. An appropriate plan of care needs to be developed by the case manager in collaboration with the patient, family, and healthcare team. An evidence-based plan should be developed with evidence-based criteria. Otherwise, an individualized plan of care is developed. The goal of planning is to develop an appropriate and financially responsible plan that takes care of the quality and does it in a cost-effective way. The case manager would seek to include contingency plans for each step of the process in the event of the health or service complications. The case manager should recognize the plan of care as a dynamic process that may require ongoing assessment and change. The facilitation of the program is the case manager actively promotes communication between all team members, patient, family, and all parties involved. There's collaboration between the patient and health team. If you enhance it, this process works well. If you don't deal with this, it can in fact break down. The case manager should use problem-solving skills and techniques in order to reconcile differing points of view, and that the wishes and needs of the patient and the patient's family are understood. The health delivery process is streamlined to focus on the best treatment or approach for the patient, thus minimizing or eliminating unnecessary steps, and does these things in a timely way. This is accomplished by coordination of the delivery of services and reduced fragmentation of care. So you've got people talking to one another. You don't have various health specialists working independently of one another. It is a team effort. The case manager should facilitate client education and understanding to prevent risk. Behaviors can come out in the patient that could in fact create high levels of risk. Advocacy. The patient's individual needs and goals are incorporated throughout the case management process. The patient is supported and educated to become empowered and self-reliant in self-advocacy. The consensus of all parties is obtained to achieve optional outcomes. Early referral is promoted to promote optimum care and cost containment, and the patient's best interests are represented by the case manager's advocacy for necessary funding, treatment, and alternatives. Successful outcomes cannot be achieved without the specialist skills and knowledge applied throughout the process. These skills include relationship building between all the team members, effective written and verbal communication, negotiation skills, because you're dealing with various medical professionals, and sometimes they have differing opinions, knowledge of the contractual arrangements, ability to affect change, to be able to go and put forward to the funders, to the various professionals, suggestions, perform ongoing evaluation and critical analysis, plan and organize effectively, and promote patient and family autonomy. The retrospective review is done afterwards. This takes place after the service has been rendered and is based on claims, review, investigative, comparative profiles, all the details that have come out at the end. And This data can lead to changes going forward in clinical practice. So you could come up with new processes that could prove to be more successful than they were in the past. These reviews would look at a cost-benefit analysis. In other words, what did it cost? What was the benefit? Is this worthwhile? Member satisfaction, the actual patient, were they satisfied? The disease profiles of this disease, did it perform better or worse? Variance reporting. If it performed better or worse than was expected, what was this? What caused this? The provider profiling. So to look at the various providers of the team, what each one put into the process, and the effectiveness of it. Then they would report back to management and can give back a program evaluation to say, this program that we've implemented is working fantastically. We should continue. It needs these improvements. It needs these changes. This provider is not fitting into the process and is a problem. Maybe we should look at a different provider. It is all about quality assurance. This is making sure that going forward, that it's a continuous improvement of the process. Disease management comprises of various interventions applied to the care of persons with a particular chronic disease. So this is now when a person's got a chronic disease and you're going to manage it for the rest of their lives. You want to improve the course and outcome of their disease. In other words, the plan you put in place to manage a chronic disease should improve the situation or at least maintain the situation, and things should not get worse. It should be preventing acute exacerbation. In other words, you do not want things to get worse. You want to improve the quality of their lives. So if you've got a patient who has got high blood pressure and you put them onto high blood pressure medication, the side effects of that medication need to be taken into account, and maybe the medication can be changed to alleviate those side effects. So disease management is looking at the fact that people have got a particular disease and they have risk factors. So if we leave things unmodified, we don't make any changes. We don't change behavior, we don't change diet, we don't change drugs, then there's going to be a deterioration of health, and potentially in the long term, it could in fact result in death. Physician-orientated interventions include encouraging the adoption and use of clinical practice guidelines. Now, clinical practice guidelines are put into place to manage the disease going forward. Patient-orientated interventions include education and other techniques aimed at improving compliance and altering the patient's lifestyle and environmental risk factors. So by simply educating the patient, you could get them to change their lifestyle, comply with the things that are being implemented, and reduce their risk factors dramatically. One needs to measure the process and outcomes success of the program. And some of the criteria for measurement include how many beneficiaries of the risk pool should be screened. In other words, how big is your sample going to be? How many identified high-risk individuals and their required annual consultations, investigations, as per the protocol, are being conducted? What is the proof that the individual has managed their disease well? Blood tests, blood pressure readings, hospital admissions, etc. The sort of programs that would be looked at for this type of thing is people who have diabetes, that are ongoing oncology, HIV management, obesity program, asthma, back problems. Pharmaceutical benefit management is where you start managing the impact, positively or negatively, of the drugs. So what are the beneficial principal effects that we're seeing? What is the desired drug reaction? What adverse drug reaction is there, if any? What rate of absorption? The convenience of handling this drug? and the storability of it. Now, there are drugs that actually are required. We heard about this during the COVID-19, that there were some of the procedures that required the drug to be kept at sub-zero temperatures, not even in a fridge, but almost in a freezer. It made it quite difficult to store and transport. The Pharmacotherapeutic Review looks at drug-drug interaction. So this drug and that drug used together, do they interact with one another? Allergy drug ratio. If someone's got this allergy and uses that drug, what are the interactions that happens? Contraindications. So if you've got, you're taking a drug and it's not doing what it's supposed to do. In fact, it seems to be actually making things worse. You need to take care of that. Therapeutic duplication. I mentioned this earlier, where these people in the movie Sicko went to the chemist in Havana, Cuba. The chemists there were like horrified. They were going, but why are you taking all of these drugs? And then when the doctor looked at it, the doctor was going, you need to take 2 of them, because a number of the things that they had been given to take was in fact a duplication. They were doing the same thing. What are the correct, appropriate dosages for age, gender, and for that condition? So what they need to look at, the product strategies that funders will adopt within respect to pharmaceuticals, is positive list. What is covered? What works? Negative list covers everything except what is on the list. These are also called exclusions. Maximal allowable prices. They will set a price that they'll say, for this type of drug, this is the maximum. Therapeutically equivalent groupings with a maximum price. And then using generic equivalents to, in fact, solve the problem. Employee wellness programs are, in fact, implemented within companies to do exactly the same sort of thing. If you've got, I know at the bank I worked at, our HR department ran a wellness program. And it was to incentivize members to participate in screening, preventative healthcare measures. For example, ladies over a certain age were encouraged to go for regular mammogram tests. Men over a certain age were recommended to go for various tests for prostate cancer and so on. People can be rewarded in many ways for taking part in the screening. And this can be, a lot of the wellness programs that are around have in fact built their success on not punishing people for not doing stuff, but rather rewarding them for doing the right thing. Wellness programs are very often between a medical scheme and a wellness provider. They actually provide this to the clients of the medical scheme. So, for example, Vitality and Multiply are wellness programs that belong to the two insurance companies concerned and are part of a partnership between the medical scheme and the wellness provider. And the medical scheme benefits due to fewer members developing high-risk preventable diseases, and obtaining more business compensates the wellness partner. So you get a double whammy in benefits. The medical aid is paying out less money because less people are sick. If this is being applied to life insurance, the life insurance company is paying out less money because less people are dying or becoming disabled. The examples for rewards could take the form of reduced fees for a participating partner, or points for members linked to discounts, which we are very familiar with from the various wellness programs that are out there. The thinking behind these programs is that the health program diagnosed early can be treated successfully and even at a lower cost. So if you catch something early, we were talking about diabetes. If someone becomes a diabetic, it could have major surgical, major health, critical illness requirements for that. But if you can pick up someone who's a bit overweight and becomes pre-diabetic, and you can treat it then, the actual treatment is quite inexpensive, and you stop these serious conditions from raising their ugly head, and obviously from having to be paid for by the medical company. The other positive is reduced absenteeism. For companies, we found this at the bank. When we did this, we were able to reduce absenteeism quite a lot because we focused on making sure that people were less stressed, improving health habits, and hopefully living longer lives, and having a more enjoyable time in the workplace. This actually definitely reduced people staying off from work. So legislation relating to managed care. There are about 40 registered managed care companies accredited by the Council for Medical Schemes. The provisions of the managed healthcare stipulates the schemes providers and beneficiaries' rights and the responsibilities with regard to accessing benefits for healthcare services. A written contract must be in place between the healthcare provider and the managed care company. Only accredited managed care companies can be contracted with. So someone, if they want to get into this business, has to in fact conform with the requirements of the Act and approval of the Council for Medical Schemes. The scheme must ensure that the managed care provider has accreditation with the Medical Council. The written protocol must be in place for all procedures. So if you've got, when there's got to be evidence of these written protocols that are in place so that when someone goes into hospital or has a problem and it starts on a managed care procedure, that there is in fact a written protocol in place that can be explained and used as a plan. There must be a system for conducting appeals, must be in place. As I said, with managed care, sometimes the fact that you have to go to specific health providers, that you have to deal with certain things and you have to do certain things, may cause patients to not want to conform with that. And they've got to have a process of appealing if they feel that their rights are being ignored. There must be consistent application of the criteria. You can't have things being applied in one way to one set of beneficiaries and in a different way. There must be fair treatment of all beneficiaries. Obviously, confidentiality must be protected. This is a health issue, so the Medical Council has serious rules in the Medical Council rules on confidentiality. This is also a financial service, part of a financial servicing, so the confidentiality requirements from FASE are there, and of course the requirements of POPI and PAIA are there as well. So confidentiality of the client's information is paramount. Only qualified healthcare providers can oversee the funding decision. So you've got this managed care process in place, but the actual funding decisions, is this going to be a PMB? Is this going to be done, and should it be paid for, is done by the healthcare professionals. The medical scheme is not absolved of any of its responsibility towards the members. So it takes on this healthcare managed care process. It appoints a company to do it, and the process is put into place. But it does not absolve the medical scheme from looking after its members. Everything must be done in the interest of the members. And guys, that's the end of this module. The last module in this program is part 6, which is healthcare performance. So read the sections in your notes, which are in your OneDrive folder, and there are also sections on healthcare performance in the new occupational certificate management, health management textbook, which is also in your library OneDrive. So please look that up, read, and prepare for the next one. I look forward to seeing you then.